This is a demonstration of the capabilities of the SafeView Endoscopic Carpal Tunnel Release system by Mission Surgical Innovations. Under intravenous sedation, the area proximal to the anticipated incisional site is infiltrated with 1% lidocaine with epinephrine. I prefer the creation of a large wheel from the flexor carpi radialis to the flexor carpi ulnaris with a small amount injected into the incision site itself to improve hemostasis. I avoid injecting into the palmar fascia, which could compromise the endoscopic view of the transverse carpal ligament. The incision is marked 1 to 2 centimeters proximal to the wrist flexion crease and spans 1 to 1.5 centimeters in length, just ulnar to the palmaris longus. The volar forearm fascia is identified and incised in line with the skin incision. Once the tenotomy tips pass through the fibers of the fascia, gentle spreading movements help to enlarge the portal opening. The proximal portion of the fascia is then sharply divided using tenotomy scissors. Dividing the forearm fascia first may simplify insertion of the cannula later. The synovial elevator is inserted deep to the forearm fascia while remaining radial to the hook of hamate. This instrument can be used to identify the distal edge of the transverse carpal ligament. The rasp can be inserted to clear away synovial tissue and improve visualization. The sequential dilators are then used to dilate the carpal tunnel space, aiming toward the third web space. The insertion depth is typically 4 to 5 centimeters. The SafeView cannula is then inserted, positioning the tip to lie just distal to the transverse carpal ligament. Posterior pressure on the hub of the cannula will help to preserve its position underneath the ligament. The distal tip of the cannula should be palpable within the palm of the hand to verify its appropriate positioning. A 4 mm 30-degree standard arthroscope is used to visualize the ligament. If necessary, the cannula can be pulled back and reinserted to help clear the visual field, particularly when there is soft tissue interposition. Transverse striations in the undersurface of the transverse carpal ligament should be clearly visualized in addition to the deep fat distally as it overlaps the ligament fibers. The clear cannula provides excellent visualization and safety. The forward cutting knife blade is then inserted through the hub of the cannula. A Ragnell retractor should be used to protect the skin during insertion of the forward cutting knife. The ligament is then divided under direct visualization. Complete release can be confirmed by visualizing the palmar fat falling into the field of view. Occasionally, a few fibers of the ligament will remain undivided. These very distal fibers can be visualized and must be divided with subsequent passes of the forward cutting knife. The cannula can then be rotated to see the cut leaflets of the transverse carpal ligament. After complete release, the cut edges of the transverse carpal ligament should be tension-free. The instruments are then removed and the dilator reinserted to ensure complete release. Once the tourniquet is deflated and hemostasis attained, skin closure is performed using 4-0 monocryl sutures with steri strips. In my practice, I apply a soft bandage to allow for light activities.